Hello everyone. Today topic is neuromuscular blockers. My name is Nirmal Kumar, assistant professor in the Department of Anesthesiology and the Critical Care Medicine, Lakshmi Narayan Medical College, Pondicherry. Before going to topic, can I know what you know about the neuromuscular blockers? Okay, yeah, neuromuscular blockers. Yeah, please tell me what you know about it. Okay, today we will discuss deeply about the neuromuscular blockers. So, what is neuromuscular blocking agent? It is also called as muscle relaxants or paralytic agents. It has been in the use in the clinical settings for almost 75 years. The neuromuscular blocking agent is also called as muscle relaxants or paralytic agents, which is in the use, clinical use for almost 75 years. Neuromuscular blocking agents plays a vital role in anesthesia. For all general anesthesia procedures, we used to give neuromuscular blocking and muscle relaxants. Again, the muscle relaxants are divided into two types: depolarizing muscle relaxant and non-depolarizing muscle relaxant. Can you tell me an example for non-depolarizing muscle relaxant? Yeah, yeah. But for before saying the example, I just want to state there even there are some subdivisions in the non-depolarizing muscle relaxant like short acting, ultra short acting, intermediate acting, long acting. Yeah. So can say, for example, for non-depolarizing muscle relaxants or acrotherium, cisacrotherium, mivacurium, vicuronium, rocuronium, pancuronium, but widely used and which is in the clinical practice daily what we are using maximum used drugs or acrotherium, which are used for some short procedures. The duration of surgery is around 1 hour or 1.5 or 2 hours. We mostly use acrotherium. If a procedure is a little longer, or like more than 6 hours or 7 to 8 hours, we mostly prefer vicuronium for the patient. Depend upon the physiological or the liver function and the kidney function, we will even change the muscle relaxants. Yeah, acrotherium is very least get metabolized in the liver, maximum get metabolized in the plasma and the kidney. So if a patient have a deranged liver function, we can prefer using the acrotherium. If the patient has a good liver function place and the procedure is really a big procedure, we can prefer vicuronium, pancuronium, rocuronium, any of these ones. Yeah. Before going to the muscle relaxant, we just want to know how the muscle relaxant has been used and how it is paralyzing the patient, how the impulse is transmitted, and something you have know the street code in the presynaptic and postsynaptic membrane, the synaptic cleft where the sodium get influx and the potassium will be coming out. So we'll just discuss a few things about the neuromuscular junction and how the neuromuscular transmission happens. So once we know about the neuromuscular junction, we know that where what is happening in and out, and what is going in and what is coming out, and what the thing is essential to block it. Yeah, before coming there, I forgot to say the depolarizing muscle relaxant. It's a succinyl choline. Yeah, succinyl choline is a rapid depolarizing muscle relaxant. Patient may have fasciculation. You can see after giving the drug, patient have the muscle movements. Patient will be fully paralyzed. And the acting on the duration of action of the succinylcholine will be maximum 5 minutes. Mainly like 2 to 3 minutes of action. The peak action will be at 120 seconds, like 2 to 3 minutes. Then slowly it get been out. And for depolarization muscle relaxation, we don't want to give any muscle reversals like neostrictine. We don't want to give to reverse it because automatically it gets reversed. We will see why and how it gets reversed. So today we will see neuromuscular junction, neuromuscular transmission, and neuromuscular blockers. So what is the anatomy? Each muscle fiber connected to the nerve fiber branch coming from the motor neuron. Each muscle fiber connected to a muscle fiber branch coming from a motor neuron. Motor neuron and all the muscle fiber it innervates called motor unit. Motor neuron and all muscle fiber it innervates called motor unit. Site at which motor neuron attached on the muscle cell, neuromuscular junction or neuromuscular junction. Site at which motor neuron attached on muscle cell is called neuromuscular junction. Stimulation from motor neuron initiates contraction process. Stimulation from motor neuron initiates the contraction process. So you can see the ventral and dorsal root of the impulse has been transmitted from the spinal cord from the ventral on to the periphery muscle fibers. You can see cell body where ventral on is there, spinal cord and the fibers, ventral fibers, ventral root and dorsal root, and where in the peripheral we can see the impulse the reach of the muscle fibers. So lower motor neuron has a cell body located in the ventral horn of the spinal cord. Motor nuclei of cranial nerves produce their axon via ventral roots to control effector organs, muscles, and glands. Each terminal fiber supplies a muscle fiber via a specialized connection called neuromuscular junction. Yeah. Motor nuclei of the cranial nerves project their axon via the ventral roots to control the effector organs. Each terminal fiber supplies a muscle fiber via a specialized connection in neuromuscular junction. It is a specialized area of the muscle fiber, axon terminal, motor end plate. Motor end plate comprised of 3 membranes called presynaptic membrane, synaptic cleft, and postsynaptic membrane. So presynaptic membrane is also called axonema. Synaptic cleft again divided into 2 types, primary cleft and subneural cleft, and postsynaptic membrane. Presynaptic membrane is called axonema. Synaptic cleft and postsynaptic membrane, secondary cleft and the postsynaptic membrane is together called the sarcolemma. So the motor end plate comprises of 3 types. Presynaptic membrane is called axonema, and the synaptic cleft where it is divided into again primary cleft and secondary cleft, and postsynaptic membrane. Secondary cleft and the synaptic cleft and the postsynaptic membrane both together called as sarcolemma. So this is the neuromuscular junction. You can see axon motor neuron, myelin sheath, the axon terminal, and the voltage gated sodium channels where it gets transmitted. You can see the acetylcholine receptor site here, the acetylcholine stress here. You can see the impulse comes, so the acetylcholine get released, sodium will go inside, and potassium will come out. And this is the muscle fiber. The voltage gated sodium channels, vesicles, acetylcholine. Neuromuscular transmission physiology. As the impulse reaches the presynaptic neuronal end, the voltage sensitive calcium channel is activated. As the impulse reaches the presynaptic neuronal end, the voltage sensitive calcium channels get activated. There are two types of calcium channels, P type and L type. P type, motor nerve endings as well as the neuronal end. L type, found in central venous system, action of the calcium channel blocker. There are two types of calcium channel, P type and L type, motor nerve ending as well as the neuronal end. L type, found in CVS, action of the calcium channel blockers. Each impulse reaching the neuronal end plate activates approximately 200 vesicles. Whenever the impulse comes from the neuronal end plate, activates approximately 200 vesicles. Each vesicle, each one of the vesicles contains 5,000 acetylcholine molecule, and thus in the each stimulation, more than a lakh of acetylcholine molecules is released into the synaptic cleft. Synaptic cleft is also called as axilloma. Yeah. So when the impulse reaching the neuronal end plate activates approximately 200 vesicles. Each vesicles contain 5,000 acetylcholine molecules, and thus in each stimulation, approximately a lakh molecules of acetylcholine is released into the synaptic cleft. Most of the acetylcholines are metabolized. Most of the acetylcholines are metabolized by cholinesterase, remaining act on the nicotinic receptors. Yes, most of the acetylcholine are metabolized by the cholinesterase, remaining act on the nicotinic receptors. Each impulse reaching the neuronal end plate activates approximately 200 vesicles. Each vesicle contains 5,000 acetylcholine molecule, and thus in the each stimulation, approximately 1 lakh molecules of acetylcholine is released into the synaptic cleft. Most of the acetylcholine are metabolized by the cholinesterase, remaining act on the nicotinic receptors. This is a graph showing depolarization, and after depolarization, you can see a spike, and this is calculated in the strength of the current in the millivolt and the time in the millisecond. You can see this threshold stimulus plus 15 millivolt, firing level minus 55 millivolt, spike potential plus 35 millivolt, early repolarization plus 35 to minus 5 millivolt. After depolarization, starts from the minus 50 millivolt to minus 70 millivolt. Yes. After the depolarization will happen after the early repolarization. So you can see threshold stimulus, firing level, spike potential, early repolarization, after depolarization. What is called depolarization? What is called depolarization? Influx of sodium ion into the postsynaptic end plate is called depolarization. Repolarization, efflux, efflux. What is influx and what is efflux? Influx, the name, the word says, which is coming inside. It's called influx. Efflux is going out. As we saw in the past picture, sodium ion will be coming inside the membrane, potassium will be given out. Yeah, influx of sodium ion into the postsynaptic end plate. Repolarization is efflux of potassium ion within the end plate to outside. What is called hyperpolarization? Prolonged opening of potassium channels causes repolarization behind the RMP. Yeah, hyperpolarization is prolonged opening of potassium channel causes the repolarization behind the RMP. Sodium channel has two gates, upper voltage dependent gate, lower time dependent gate. The upper gate opens when the stimuli is applied and the remaining gate will be closed until the stimuli is cut off. Whereas the lower gate is time dependent and closes after the interval of time 1 to 2 milliseconds. Sodium channel has two gates, upper voltage dependent gate and lower time dependent gate. So the two channels are upper one is voltage dependent gate and lower one is time dependent gate. So it's depend upon the impulse of the voltage and the lower gate when it gets closed, the time dependent one as soon as the voltage intensity comes down, the time it start closing. So the upper gate open when the stimuli is applied and remaining open until the stimuli is cut off. Whereas the lower gate is time dependent, it closes after interval of time 1 to 2 milliseconds. When the stimuli is applied, the upper voltage sensitive gate opens as well as the time dependent gate is open, allowing the sodium to flow in the activated channel. When the stimuli is applied, the upper voltage sensitive gate opens upper as well as the time dependent gate is open, allowing the sodium to flow in called activated channel, resulting in the sodium influx inside, which in turn will cause depolarization, muscle contraction, resulting in the sodium influx inside, which in turn will cause depolarization, muscle contraction. The sudden voltage change in adjacent sodium moves to the next channel, resulting in the wave throughout the muscle fibers, causing contraction. The sudden voltage change in adjacent sodium. The sudden voltage change in adjacent sodium moves to the next channel, resulting in the wave throughout the muscle fiber, causing contraction. You can see neuromuscular junction where the acetylcholine released after the calcium influx. Synaptic cleft where the acetylcholine has been released, and you can see the nerve terminal there. Calcium goes inside, acetylcholine gets released. The voltage dependent potassium channel then opens, resulting in efflux of potassium out of cell, resulting in repolarization. The voltage dependent potassium channel then opens, resulting in efflux of potassium out resulting in repolarization. As the positive charge moves out, it becomes negatively charged, reaches the resting membrane potential. Reaching resting membrane potential, the upper gate closes, the lower gate opens. Reaching the resting membrane potential, the upper gate closes, the lower gate opens. Neuromuscular transmission, presynaptic events, and AP propagates down the axon, invades and depolarizes the presynaptic terminal region. Propagates down the axon, invades and depolarizes the presynaptic terminal region. Calcium flows into the photons through voltage activated calcium channels. Calcium flows into the photons through voltage activated calcium channels. Fusion of synaptic vesicles with presynaptic membrane and the release of packets or the contour of transmitter into the cleft. Fusion of synaptic vesicles with presynaptic membrane and the release of packets or quanta of transmitter into the cleft. Most of the vesicles contain more or less the same amount of transmitter, referred as one quanta. So you can see the vesicles, almost all of the vesicles will have the same amount of transmitter. This is referred as quanta. Neuromuscular junction, the transmitter released is acetylcholine. The neuromuscular junction, the transmitter released is acetylcholine. It is important to note that the amount of transmitter released is directly related to the amount of calcium that enters the boton, which is directly related to the number, amplitude, and duration of the invading action potentials. It is important to note that the amount of transmitter released is directly related to the amount of calcium that enters the boton, which is directly related to the number of amplitude and the duration of the invading potentials. The duration of the invading potentials. Calcium channels involved are not located in the axon, only at the terminal bottoms. The vesicles fuse to the terminal membrane via specialized docking proteins. The vesicles fuse to the terminal membrane via specialized docking proteins. Vesicle membrane is recycled, but that system can be overwhelmed. Vesicles membrane is recycled, but the system can be overwhelmed. For diffusers across the cleft, it takes time up to several hundred microseconds. Acetylcholine binds to nicotinic acetylcholine receptors in the postsynaptic membrane, opening monovalent cation channels. Acetylcholine binds to nicotinic acetylcholine receptors in the postsynaptic membrane, opening monovalent cation channels. Channel opening depolarizes the postsynaptic membrane, creating an end-plate potential. Channel opening depolarizes the postsynaptic membrane, creating an end-plate potential for EPP. If EPP's end-plate potential exceeds the threshold value, then the voltage activated sodium channels open, giving rise to the muscle. Termination of transmission process occurs via hydrolysis of acetylcholine. by acetylcholinesterase present in the junction. Termination of transmission process occurs via the hydrolysis of acetylcholine by acetylcholinesterase present in the junction. Neuromuscular blockers. As I said earlier, there are two types of neuromuscular blocking agents: drugs, depolarizing blocking agents, non-depolarizing blocking agents. Non-depolarizing blocking agents is all classified into three types: long-acting, intermittent-acting, short-acting. Long-acting, for example, D-tubercularine is the first drug in the invented the beginning. Pamphronium, doxorubicin, pipocuronium. Intermittent acting or vicronium, atracurium, cistatacurium, procuronium, rapacurium. The short acting or mivacurium. Succinyl depolarizing muscle relaxant. Depolarizing blockers or succinylcholine and dicamethonium. Dicamethonium we are not using, succinylcholine is under use. So the two types of muscle relaxant, non-depolarizing and depolarizing blockers. Non-depolarizing, three types: long-acting, non-depolarizing blockers are three types: long-acting, intermittent-acting, and short-acting. Depolarizing blockers are succinylcholine. Long-acting are D-tubercularium, pancuronium, toxicuronium, pipocuronium. Intermediate-acting are vicronium, atracurium, cisalpacurium, rocuronium, rapacurium. And short-acting are mivacurium. So coming to succinylcholine, it's a depolarizing neuromuscular blockers act as the agonist. Produce muscle relaxation by directly depolarizing the acetylcholinesterase and acetylcholinesterase. So the succinylcholine will directly act as a depolarizing muscle relaxant and which directly depolarize the N-acetylcholinesterase. Succinylcholine is made up of two acetylcholine molecules joined end to end, which act as a false transmitter, mimicking as acetylcholine. This is the action like how the succinylcholine act. And succinylcholine is made up of two acetylcholine molecules joined end to end, which act as a false transmitter, mimicking as a acetylcholine. So this is the succinylcholine structure, and you can see the acetylcholine structure, which is more equally or more resembled like the succinylcholine. Mechanism of action. Each acetylcholine receptor has two receptive sites, and activation of the receptor requires binding to both of them. Each receptor site is located at one of the two alpha subunits of the receptor. Each acetylcholine receptor has two receptive sites, and activation of receptors requires binding to both of them. Each receptor site is located at one of the two alpha subunits of the receptor. In the resting state, the ion channel of the acetylcholine receptors is closed. Binding acetylcholine binding of acetylcholine molecule to uh, binding after two acetylcholine molecule binding of two acetylcholine molecule to two alpha subunits initiates the conformational changes. Result in the opening of the channel. So, prolonged depolation of the end plate, inactivation of voltage-gated sodium channels at the neuromuscular junction, inactivation of voltage-gated sodium channels at the NMJ junction, result in failure of action potential generation due to membrane hyperpolarization. Depolarizing phase bind in the acetylcholine receptor, causing the sodium channel result in the depolarization. It does not proceed to repolarization or resting phase. The phase 2 blockade, desensitizing phase. Phase 2 blockade is also called desensitizing phase. Continuous exposure or repetitive dose of succinylcholine. Once you give more than once, like twice or thrice, depending upon the patient, repeated dose of succinylcholine cause inactivation of sodium channel and repolarization occurs, and depolarization does not occur, causing paralysis for long hours. Usually, succinylcholine after giving a succinylcholine patient will be coming out in the 5 minutes maximum. But when you give a repeated dose, it takes a much long time, or patient will not even come out, or sometimes it requires to give a reversal agent for succinylcholine. It depends upon the patient. Sometimes the races also matter, because if you race to the pay of patient will have absence of acetylcholine, so and even when you give the multiple dose, depolarization does not occur, and then will be a paralysis for long time. It's called chain of four. Enzymes of importance. Metabolized, mostly metabolized by pseudocholinesterase, produced in the liver, present in plasma. Half-life is 5 to 12 days. Metabolized 70% of 100 mg per succinylcholine within 1 minute. So it gets metabolized within 1 minute. The 70% of the drug what we use it gets metabolized. Only 10 to 50% of injected succinylcholine reaches the neuromuscular junction. When you give 100 mg bolus, only 10 to 15 mg will reach the neuromuscular junction. Remaining it gets metabolized in the during when it reaches, before it reaches. Unlike acetylcholine, the succinylcholine is now metabolized in synaptic cleft. But the succinylcholine from the cleft diffuses back to the plasma to maintain the concentration gradient. Succinylcholine from the cleft diffuses back to the plasma to maintain the concentration gradient. Factors affecting neurocholinesterase activity, liver is like liver disease, reduced production, more duration of action, advanced age, malnutrition, pregnancy, burns. The drugs like neoplastic drugs, anticholinesterase, and beta blockers, esmolol. Choline apnea. When choline is not metabolized in the plasma, it acts as a nicotine receptor for longer duration of time, resulting in choline apnea or post anesthesia apnea. When choline is not metabolized in plasma, it acts on the nicotinic receptor for longer duration of time, resulting in choline apnea or post anesthetic apnea. Atypical pseudocholinesterase incidence was found in the Arya Vaishya community. found in Andhra, Karnataka, Tamil Nadu, Maharashtra, and Odisha. So pseudocholinesterase incidence will be seen in the Arya Vaishya community. This community people will have a pseudocholinesterase where we can see the prolonged action of schooling. In this community, people should not give or avoid giving schooling because the action will be more prolonged, sometimes it will cause more complications. Dosage succinylcholine can be administered IV, most common. We can give intraosseous also, intralingual or intramuscular. IM would onset delayed and duration of action is long lasting. So mostly preferred route is IV, intravenous. Average single bolus is 1.1 to 1.5 the maximum 2 mg per kg IV. The duration of action is 5 to 10 minutes. For continuous infusion, you can give 20 to 40 max per kg per minute, but most of the time you won't use a continuous infusion. Rapid onset effect, profound depth of neuromuscular blockage, short duration of action, used for intubation. Intubation 1 mg per kg with 60 seconds of onset of action, lasting for 9 to 13 minutes, but maximum we can see 5 minutes. Repeated small bolus of 10 mg small interval can be used for short surgical procedure, which requires a brief but intense muscle relaxation. Repeated small bolus dose of 10 mg at a small interval can be used for short surgical procedure, which requires a brief but intense muscle relaxation. Adverse effects: cardiovascular system, fasciculations, hyperkalemia, muscle pain, intragastric pressure elevation, intraocular pressure elevation. All intracranial, intraocular, intragastric pressure will get elevated. Muscle rigidity. You can see the patient after giving sustainable, you can see the muscle get rigid and fasciculations will be there. And malignant hyperthermia is one of the complications. And prolonged paralysis will be there if you give a patient with diabetes or pseudocholinesterase like Arya Vaishya community people, or if you go into the dose for 2 or more times, we can see prolonged paralysis. What are the adverse effects in the cardiovascular system? Sinus Reddy, inhibited SA node, usually seen in the patient with the second dose of succinylcholine with 5 minutes of first dose due to metabolic succinylcholine, which causes direct myocardial inhibition, increased muscular stimulation, ganglionic stimulation, suppression of the SA node, emergency of AV node as a pacemaker, ventricular dysarrhythmias such as succinylcholine reduces threshold of ventricle to catecholamines, resulting in increased ectopic activity, arrhythmogenic effect. Anesthetic drugs such as halothane lowers ventricular threshold for ectopic and arrhythmogenic property of succinylcholine. Glycopyrrolate can be used for bradycardia. Hyperkalemia. Increased potassium level after succinylcholine results due to efflux of potassium from the muscle during fasciculation. Succinylcholine increases the plasma potassium of 0.5 millimole per liter in normal individual. Severe hyperkalemia occurs in a patient with metabolic acidosis and hypovolemia. In some conditions, the presence of nicotinic receptors in outer surface of muscle, succinylcholine act more vigorously, resulting in excessive potassium release. In some conditions, the presence of nicotinic receptors in outer surface of muscle, succinylcholine act more vigorously, resulting in excessive potassium release. There are massive wounds, massive muscle trauma, skeletal muscles, and this is a renal failure. Increased intraocular pressure causes tonic contraction of extraocular muscles. Occurs within 1 minute of injection, peaks at the 2 to 4 minutes, subside by 6 minutes. Transient dilatation of cordial blood vessels. Increase intragastric pressure, increase of intragastric pressure up to 30 centimeters of water occurs due to oscillations of abdomen muscles. Acetylcholine like effect of succinylcholine causing vagal stimulation and increase the intragastric pressure. Succinylcholine triggers hyperpyrexia in the presence anesthetized with halothane. This hypermetabolic disorder of skeletal muscle cause myalgia and muscular spasm, non-depressing muscle aches. The drug does not depolarize the motor end. The quaternary ammonium muscle relaxant belongs to this class. What are the mechanism of actions? Each acetylcholine receptor has two receptive sites. An activation of receptor requires binding of both of them. Each receptor site is located at one of the two subunits in the receptor. Quaternary muscle relaxants bind to nicotinic acetylcholine receptor and inhibit or interferes with the binding and effect of acetylcholine to the receptor. They are competitive antagonists combined with the nicotinic acetylcholine receptor at the end plate and thereby completely block the binding of acetylcholine. So, quaternary muscle relaxant bind to the nicotinic acetylcholine receptor and inhibit or interfere with the binding and effect of acetylcholine receptor. There are competitive antagonists combined with the nicotinic acetylcholine receptor at the end plate and thereby completely block the binding of acetylcholine. Depolarizing muscle relaxant, non-depolarizing muscle relaxant. Bind to a subunit in the same way, alpha subunit in the same way that acetylcholine does. If bind to paired alpha subunits, stimulate and initiate opening of ion channel, producing a contraction known as fasciculations. These drugs are not broken down by acetylcholinesterase. They bind for longer period than acetylcholine, persistent depolarizing of the inlet and neuromuscular block. Non-depolarizing muscle relaxant. Non-depolarizing muscle relaxants compete with the acetylcholine to bind to a alpha subunit. Attachment to a alpha subunit does not open the ion channel, so no current will flow through the channel. Membrane will not depolarize. Muscle will become flaccid. So the depolarizing muscle relaxant bind to alpha subunit in the same way that acetylcholine does. If bind to a pair of alpha subunits, stimulate an initial opening of ion channel, producing a contraction known as an fasciculation. These drugs are not broken down by acetylcholinesterase. They bind for longer period than acetylcholine, persistent depolarization of the inlet and the neuromuscular block. Non-depolarizing muscle relaxants compete with acetylcholine to bind a subunit. Attachment of alpha subunit does not open the ion channel, so no current will flow through the channel. Membrane will not depolarize. Muscle become flaccid. Based on duration of action, non-depolarizing muscle relaxants can see mivacurium, it's a short-acting one, which acts only for 15 to 20 minutes. Intermediate acting or atracurium, cisatracurium, vecuronium, procuronium, which acts for 20 to 15 minutes maximum. And the long-acting or pancuronium, doxycurium, tipicuronium, which acts more than an hour. Once you give a bolus dose, after the top-up dose, which you used to give intermittently, which intermediate dose. If you give mivacurium, you should give within 15 20 minutes of time. But when you choose intermediate acting, you can give after 30 to 40 minutes. When you choose the pancreatum like a long acting breast, it will come for 1 hour. Every 1 hour, you should give a top of dose. So this by structural classification into steroid components and benzyl quinoline components. The steroid components are pancuronium, pecuronium, pipacuronium, rocuronium, and trapacuronium. Benzyl quinoline compounds are D-tryptopyrin, metocurrin, doxycurium, atracurium, nivacurium, cis-atracurium, and others are galamine and curonium. Benzyl quinoline components are D-tryptopyrin, metocurrin, doxycurium, atracurium, nivacurium, cis-atracurium, while the steroidal components are pancuronium, mecuronium, pipacuronium, docuronium, pipacuronium, and others are galamine, alpuronium. Pharmacokinetics classification, like large hydrophilic molecules, IV administration necessary, quaternary ammonium bases like positive charge, poor permeation, and placenta GAT, benzyl stolins or D-tryptopyrin and galamine, mivacurium, atracurium, cis-atracurium. Steroid molecules are pancuronium, pipacuronium, rocuronium, and vecuronium. Stimulation of muscles during the prolonged administration. Non-depolarizing competitive blockers (MOA). The site of the action of the both competitive and the depolarizing blockers is the end plane of the skeletal muscle fibers. Pharmacological actions: skeletal muscles, intravenous injection of non-depolarizing